Niall Dickson, Chief Executive of the NHS Confederation, represents 85% of NHS providers and commissioners. Neil, how are you?
I'm well, thank you.
Good to see you. Right, patients are going to have to wait longer for routine operations. The trade-off. Tell us more.
Well, I think this was inevitable that they were going to have to relax some performance measures in the health service. The level of pressure, which almost every bit of the NHS, not just accident and emergency that we hear quite a lot about, but mental health services in the community, GP services, they're all under enormous pressure. And if the government and NHS England are wanting more and better things from some areas, they're obviously going to have to trade, as it were, some of the other things. And the level of funding at the moment, we've been through a period of austerity, the like of which the NHS has really not seen in its history. And that followed some years of plenty, when a great deal of money went into the NHS. And I think that a lot of organisations are just feeling the pressure at the moment. But I don't think we should give up any of these targets or measures lightly. The fact is, in around 2000, people used to have to wait 18 months, not 18 weeks, 18 months and longer for operations. And certainly I think everybody will be hoping that this isn't a slide back into a situation where people are waiting a long time.
The pressure is entirely financial, is it?
No, I think the pressure is partly financial, but it's really about demand. It's the fact that we now have this ageing population that we keep on hearing about, many elderly people with more healthy life years, which is great, but also unhealthy life years. And we've got a system which is really not designed for it. It was a system designed in the 20th century. The new demands that are being made upon it, the system simply doesn't cope. It's too fractured, it's too fragmented. And this plan that they've produced today is an attempt to say we need to have a new way of working within the health service. And I think a lot of health service organisations are very much up for that, but they are trying to cope at the moment with unprecedented levels of pressure.
So what patients will go to the back of the queue or further down the queue?
Well, I suspect that it'll be patients who require non-urgent operations will wait a bit longer. And the question is,
like
what does that?
Or a knee?
Yes, it might be somebody coming in for some kind of orthopaedic intervention of that kind. And if it's a marginal increase, I don't think that necessarily is such a terrible thing. But I think if we simply allow ourselves to go back to where we were 15 or 16 years ago, that would be a very retrograde step. And it simply represents the fact that this is a system trying to cope with huge extra demand with very limited resources.
Ageing population and increased population?
Yes, a bit of that, and also expectations. People's expectations of what they want from the health service, I think, are increasing. And again, managing that in a sensible way, and remembering that an awful lot of this is less about people needing hips and knees, which they absolutely do need as they age, but also a very large number of people with long-term conditions who need to be managed better in the community so that they don't end up putting pressure on the hospital services. And it's redesigning the services so that people are treated at an earlier stage or kept and supported in their own homes, out of hospitals, rather than the situation where they're ending up ill and not able to cope because they've had some kind of crisis, and that's which puts huge pressure on hospital services.
A couple of other areas just to address here. What about those operations which are controversial? Some people say, you shouldn't be able to get that on the NHS. Others argue, they're absolutely for my psychological well-being. I should be able to get that on the NHS. I know, sometimes people say that of breast reduction operations, for example. And can you think of some others? I'm sure you can. But what about that particular area?
Well, quite a lot of cosmetic stuff is not, you're not able to get on the NHS.
You can sometimes.
But you can sometimes. So it's not an absolute line. There's not a line that says...
I'm just wondering if that line's going to move.
Well, it may have to move. And I think we have to have an honest conversation as a society. You simply cannot expect the NHS to do everything. I mean, earlier this week, NHS England announced the issue of issuing through prescriptions drugs that cost a few pence to buy over the counter that we're providing on prescription and costing the NHS millions of pounds. That's clearly ludicrous. And likewise, treatments where there isn't a real clinical need, I think it's perfectly legitimate for those who are commissioning services, if they've got the evidence that it is of limited clinical value, I think it's reasonable to say that the NHS should not be providing them.
As I say, it's subjective. Gender dysphoria is another area, isn't it?
Yes, and I think you do have to be careful in particular areas. The psychological effect of some of these things that people find difficult can be enormous for that individual, and indeed the need for it may be absolute. So I don't think one can always come across and say this is a blanket ban on this, that and the next thing. Sometimes it has to be the decision of the individual clinician. But I think that those who are paying for services and who have very limited amounts of money will have to make difficult decisions. And I think what we're saying is that we hope that we'll get public understanding, but we also need politicians.
Yeah, when it comes down to a bureaucratic decision, sometimes the humanity is taken out of the equation. I suppose that's going to be the concern of a lot of people. Someone's, psychological well-being. It's more than just subjective as far as they're concerned. But listen, that's an interesting area. According to this report as well, hundreds of thousands of patients will no longer be referred to a consultant by their GP. Neil, how's that going to work?
Well, where there isn't a need to refer to a consultant by a GP, that's a really good thing. Sometimes I think the report also refers to the need to refer cancer patients more quickly into those suspected of having cancer. So it is important, and I think general practitioners are all over the country are working out ways in which you refer more effectively into the system so that you're also able to provide that support in the community, which means that people don't need to be referred into the hospital services. Yeah,
just finally, NHS staff listening this morning, and they are many, they have to make life and death decisions. They'll be listening to you, Neil, and the story as it unfolds throughout the day and as it is presented, and thinking, is this going to make my job harder? What's going on here? I suppose it will.
Yes, I think the NHS and all the staff in the NHS are facing really very difficult times at the moment, and I think that acknowledging that is really important in terms of the politicians and those who run health services. The fact is that the current system puts them under more pressure than they need to be under. If we can reorganise that service and get it more effective with better out-of-hospital care, you will be able to relieve some of that pressure. So there is a problem with money, but there's also a problem of reorganising the services in a better way.
Thank you very much indeed, Neil. Niall Dickson, Chief Executive of the NHS Confederation, which represents 85% of NHS providers and commissioners.